And I would like to thank the previous speakers for their presentations. I would like to thank the audience for being here at such a late hour in the evening. And I will focus on the relationship between chronotype and depression. Uh, and circadian rhythm is actually affecting us because we know that we have the Zeitgeber and we have lots of stimulants and they actually trigger the SCN, and from the pineal gland there is a stop to the release of melatonin, and we have suprachiasmatic nucleus, and also we have the pineal gland that actually peaks the level. With the circadian rhythm changes from infancy to older ages, and as you go older, you might have different activities at different times. We know that walking activity, temperature, melatonin, cortisol, plasma glucose, and SCN firing levels change and they go down by age. And the older people always complain that I cannot sleep at night, and this physiological parameter changes affect them and their sleep. In normal circadian rhythm, the melatonin release is starting 2 hours before the bedtime, and the body temperature is going down in the middle of the night, especially the lowest in the middle of the night. And so also cortisol levels, it is very low, and when we wake up it peaks. When we compare healthy controls and depression subjects, we can say that in healthy controls body temperature peaks, and also there is a range difference at the highest and lowest levels. And in depression we see that highest level and lowest level range in body temperature is smaller. In terms of cortisol levels, when compared to healthy controls, in depression patient it's much higher, and the melatonin peak cannot be achieved in depression patients, so they may have some sleep disorders accompanying the condition.
Sirkadiyen ritimdeki bozulmalar nasıl?
What about the disruptions in circadian rhythm? There is a phase delay in circadian rhythm. In depressive cases, just because melatonin release is delayed, so they get up later time, and they feel tired throughout the day, and they feel more sleepy during the day. I'm gonna talk about the morning and evening chronotypes. Melatonin release time is different with different chronotypes. For the evening chronotype, it's there is a 2 hours of phase shift. Depressive disorders pathogenesis is explained by the circadian rhythm disruption. Disruption in circadian rhythm can increase disposition to depression, and there is a two-way relationship between them. There's a bidirectional relationship. So those working at night shifts and those who are subject to blue light, affective symptoms are more. They are more prone to depressive symptoms. Pathophysiology of mood disorders. In depressive cases, there are changes and fluctuation within the time. So sleep regulation and chronobiological mechanisms, we need to understand them better. In depression, circadian rhythm parameters when they're examined one by one. Circadian rhythm and mood. In healthy subjects, there are mood swings, and more than 800 million Twitter messages were evaluated. Morning hours are more associated with positive affect. However, at night time, words associated with anger are used. uh, Depression, in the progression of depression, evening chronotype is a risk factor. Being depressive and evening chronotype, what is it different from the morning types? Their depression scores are higher, they have more suicidal thoughts, and their sleep quality is better. A morning chronotype is protective against depression, and the severity of the episode is lower. Evening chronotype, there is a 2 hour phase shift, and it's more disrupted. Throughout the day, mood swings and chronotypes, the results are different. In some studies, those with depression and evening chronotype, their mood swings deteriorate in the morning. However, there are some other studies suggesting that mood swings start at the late hours of the morning, and by nighttime, depressive symptoms are increasing. Morris et al. Performed a study evaluating deterioration symptoms of it. 32% in the mornings, 30% in the afternoon, and some of them had deteriorations at night time. I'm gonna talk about 3 main inputs. Suprachiasmatic nucleus doesn't get stimulus from outside, but there is an intensive serotonergic pathway stimulating it. So it's one of the most important neurotransmitters. So in the basal forebrain and preoptic area, it makes a connection, and it regulates sleep-wake cycles. Circadian rhythm and mood disorders, and how about stress? As mentioned very well, Ayşe, HPA axis is stimulated, and there's a dysfunction, and depression predisposition increases. Acute stress and chronic stress responses are different. In acute stress, tryptophan 5-HT firing increases, which is better. However, in chronic stress, neurogenesis reduces and depressive symptoms increase. It's not only that pathway affecting it, cortisol and serotonin destruction increases, resulting in decrease in serotonin level, and the depressive symptoms increase. Under normal conditions, stress system is under the control of the circadian stream, and under stress, the body goes to active and awake phase. When stress signals decrease, the organism rests, and the resources required for the active phase are stored. Stress system, there is a continuous feedback between stress and circadian system, and 5-HT system is under circadian control, and stress, daily rhythmic glucocorticoid secretion affects serotonin release. Another parameter is the sleep phase changes, REM latency. When we go into the bed for the first time until the start of first REM is called as REM latency. It's shorter in depressive cases. So depressive cases go into REM sleep as soon as they go into sleep. The latency is shortened, however, Non-REM, REM, is lower in depressive cases. Shortened REM latency, increased REM sleep duration, and increased REM density can be considered as biological markers of depression. Individuals with depression, their healthy relatives are taken into consideration in studies. Shortening of REM latency and elongation of REM amount. So sleep disorders may develop even before depression. So could it be considered as a biomarker? Sleep disturbances are a risk factor for poor clinical outcome in depression, and insomnia can occur before the onset of depression, and sleep disturbances are related with suicidal thoughts. Another impaired parameter, in depressive patients, there is a progression in cortisol levels. So cortisol peaks in the morning after waking up, but there is a 2-3 hours of progression in depressive patients. However, it is a more flat amplitude in depression, and it's more on the higher side. Dexamethasone, after dexamethasone, suppression of cortisol is disrupted in depressive cases. Increased cortisol levels, and even during remission of depression, they may stay high. So this increases the recurrence of the episode. Increased elevated cortisol levels are associated with decreased hippocampal neurogenesis and increased neurotoxicity. So we do not like chronic stress, which is highly related to depression. What about the body temperature in depression? The nighttime body temperature in depressive cases is higher, but the range between highest and lowest body temperature in depressive cases is narrower. Dopamine, serotonin, tryptophan have a role in the etiology of this. These are directly involved in melatonin synthesis, and serotonergic system is related with mood and circadian rhythm. Suprachiasmatic nucleus can be stimulated. How about the effects of treatments on circadian rhythms? Non-pharmacological treatments, sleep deprivation, light therapy, interpersonal and social rhythm therapies have shown antidepressant effects. Total sleep deprivation, especially patients, 50-60% of patients, there is an improvement in depressive mood, but this is temporary, because after a total sleep, that improvement in sleep behavior is not there. Partial sleep deprivation, it's deprivation of sleep 1 hour in the second half of the night that reduces depressive symptoms, but this effect is not as strong as total sleep deprivation. I love this image. In the dark, suprachiasmatic nucleus, you see, and under light, when there is light, serotonin is produced, and we go into active phase, and serotonergic system is stimulated, which increases its generation. Light therapy is considered as first-line treatment for SAD. However, it's not only for seasonal affective disorders, but in non-SAD, it is found to be effective in reducing mood symptoms. Social Zeitberg theory. These are the unmet social needs or impaired interpersonal relations and depression. If we improve interpersonal relations, we improve the mood, and it has positive effects. I'm going to talk about Agomelatin, it says melatonin 1 and 2 receptor agonists can resynchronize the circadian rhythm. Even there is no melatonin production from the pineal gland, it resets the circadian rhythm by binding to melatonin 1 and 2 receptors. And dopamine and norepinephrine release is increased. And delayed phase in depression shifts towards healthy controls. Tricyclic antidepressants suppress REM sleep, increase REM latency, and decreases the amount of REM sleep. So impaired sleep cycle is normalized. Oxidase inhibitors and SSRIs are also used to suppress REM sleep and prolong REM latency, because in depression it's shortened. SSRIs do not increase serotonin in synaptic cleft and hippocampal neurogenesis. It also has effects on circadian rhythms by advancing the phase. 5-HT is important for normal circadian function, and as I stated, in circadian rhythm, serotonin is important. Electroconvulsive therapy and transcranial magnetic stimulation increases in REM latency. ECT also normalizes circadian temperature in depressed patients, and both circadian system and both on sleep, they have positive impacts. Thank you for your attention.